Everybody. Uh, slide here.
Ma'am, your voice is a bit low.
Sorry.
We can't hear you clearly, ma'am.
Oh, really?
It's okay now.
Is it?
Yes.
Senior, could you just tell me if the slides are moving?
Yes, ma'am. The slides are moving.
All right. Thank you. Yes. Good evening, everybody. So I know that you have finished your first class on gastrointestinal symptoms, mainly focusing on nausea and vomiting. And today we are going to be looking into the second part of gastrointestinal symptoms, and that is management of bowel obstruction. So we will be also looking into what are the different types of bowel obstruction, what how to manage malignant bowel obstruction. Okay, so having said that, the main focus for today's class will be on the classification of intestinal obstruction and what are the symptoms that the patients are going to present to you with, which will tell you that yes, you are looking at intestinal obstruction, and how will you come to a diagnosis, and how are you going to manage once you know it is. So now what are you going to do about it, and in palliative care, how do you treat intestinal? So this is basically going to be a session where I would like to have it should be rather like an exchange of views over here. Okay? So I would like each of you to participate, and you can put in your whatever you have to say in the chat box. Please use it liberally, or you can just unmute and speak. And let us make this a very interesting discussion, because I think it's more of a learning process where we are learning from each other, because all of us are practicing in one area or the other, have seen patients, and most of us would have seen patients, and we have seen malignant bowel obstructions, and how it is being managed in each of your institutes may be different. So it's a learning point for each one. Okay. So I would like to begin today's session with a case scenario. Here we have Sarah, who is a widower, she is a 62-year-old woman who was diagnosed with stage 4 of the stomach, gastric adenocarcinoma, with metastasis to the peritoneum and anterior abdominal wall. She had also a palliative distal gastrectomy, which was done, following which she was asked to take chemotherapy. But unfortunately, a CT scan, which was done after 2 cycles of chemotherapy, showed that she has progression of disease, okay, in the peritoneum and abdominal. So I want you to think of this case. Okay? These points that I have put in red have to strike you in such a way that these are areas which have to be focused to, where you are going to think about how to plan your management, your palliative management for this. Now, this is something I want you to think, because we are going to come back to this case report after today's session. And let us see how differently you are able to think after this. Okay. So I'll go to the next slide. Yeah, but before we get into that, so would you like to share your ideas on what are the different types of obstruction that you have seen, or what could be the different reasons why there is an obstruction that is happening in the intestine? Yes, you can use the chat box. Why do you think there is, I mean, what could be the reasons why there is a obstruction that is happening in the intestine? Chat box? Yeah. Dr. Chidananda says that it could be a peritoneal metastasis. Absolutely. Could be one of the reasons. Dr. Aurora says it could be malignancy. It's a tumor sitting right there on that intestine and causing the obstruction. Yes. And also it could be constipation. Yes. Very true. There could be a fecal mass which is sitting there and causing obstruction. Yes. And Dr. Vasantha says it could be secondaries or lymph nodes. Secondary lymph nodes, which is again like a tumor mass which is sitting on to the intestine or probably infiltrating into the intestine and causing it. Yes, again, we have another suggestion that could be because of surgical adhesions. Very true. Post-op adhesions. Dr. Shivakumar also agrees to that. And Dr. Arora says it could be gastric outlet obstruction, which again could probably as a sequelae, probably a malignancy, but as a sequelae, has also led on to the obstruction. Yes. Any other? Yes, we have absolutely. Dr. Shika says electrolyte disturbances, hypokalemia. Dr. Kumar says hypokalemia. Yes. So you would have something sitting over there or infiltrating the intestine, or you could have some electrolyte imbalances, which is causing some kind of impairment in the motility of the intestine, which is leading to the so-called obstruction, isn't it? Yes. So having said that, let's just go on to, thank you for your responses. And having said that, let's just move on to what are the different types of intestinal obstruction. So you could mainly classify them into non-mechanical and mechanical. Yes, like some of you said, they could be hypokalemia, there could be electrolyte disturbances. This is what we call as function obstruction, and this would lead to adynamic bowel, where there is absence of normal peristaltic contractions. And even when you examine or auscultate, you can see that the bowel sounds are absent, right? So, and here, when you compare with patients who present with a mechanical obstruction, you can also notice that the pain is lesser for non-mechanical obstruction. So in mechanical obstruction, again, it has been classified further according to what is the cause or what is the type. Was it really fast? Was it like slow over the weeks that happened? So you could classify it as something like acute or chronic, or something which was chronic and managing it for some time, and then again it has come up. So it would be an acute on chronic situation then. Or say according to the site, say it is in the small bowel or the large bowel, or if according to the nature, if it is just a simple obstruction, is it a closed loop obstruction, or is it like a strangulation, where even the vascular supply is being obstructed. And then you have something which is like, according to the etiology, it could be intrinsic, where the mass is inside, where it's extrinsic, where it is outside the lumen, or it is intraluminal, where it is infiltrating. It's intraluminal, right? So here, like you can see here, mechanical obstruction is of two types: small bowel, according to the site. It can be a small bowel intestinal obstruction, or it can be a large bowel intestinal obstruction. So how do you think you can make out where the obstruction is for a patient? So you are seeing a patient and you think the patient is having an obstruction, and you would like to know where is the obstruction? Is it in the small bowel or the large bowel? How do you think you can know? Yes, chat box. What is kind of going to give you the idea? Okay, looks like this patient is having obstruction in the small bowel, or this particular thing that you are looking at is probably a large bowel obstruction. Any ideas? Okay, we have suggestions like Dr. Kamakshi says it could be a tense abdomen. Dr. Shiva Kumar says it could be a total obstipation where there is absolutely no fecal mass or no fecal obstipation when it is a large bowel obstruction. And Dr. Arora says it could be probably a greenish vomitus. So, where do you think it could be? This greenish vomitus. Or would it be a small bowel? Would it be a large bowel? Yes. So do you think that, most often when we have a patient yes, we have another point over here, persistent vomiting if small bowel and obstipation if large bowel. Yes, that is one of the points that Kim Chidananda has given us today. So let us see more about each one of these. Okay. Thank you for your responses. And yes, I just have another slide here saying, what is simple obstruction, what is closed loop obstruction, and what is triangulated obstruction. So these are just the different types where you can see there is actually a vascular compromise where when it is strangulated. Okay? So when there is a strangulation, it calls for an emergency. The pain is much sharper, there is peritonism, there is fever, there are signs of mesenteric ischemia. Okay, it's absolutely an emergency. It could even lead to gangrene. Yeah. So so we were coming to, we had also discussed, before we come to the previous point that we were discussing, the small bowel and the large bowel, we had also been discussing about the causes of mechanical, the different causes of obstruction. So you did say that, yes, there is mechanical, there is non-mechanical, that's you were talking about the serum electrolyte parts, and then you were talking about the tumors, isn't it? So coming to the mechanical obstruction, what all could it be? Like some of you had said, it could be post-op adhesions. Some of you had said it's probably a tumor. It is like a malignancy that is there. And some of you had said it is probably it's a constipation. It's an impaction, right? So this, the causes for mechanical obstruction, as you can see here, it has been further divided into intraluminal, that's inside the lumen, intramural, that is within the wall of the intestine, and extramural, which is sitting probably outside the intestinal lumen. Okay. So intraluminal, you have impaction. It can be anything. It can be fecal mass. It can be foreign bodies. It can be basoils. It can be gallstone. Okay. But intramural is rather like a tumor which is within the wall of the intestine, or it can be a stricture that is formed. Strictures can be because of multiple reasons. It can be because of surgeries that had been post-op, or it can be because of radiation that has happened. Strictures can be because of various reasons. Then you have extramural. Extramural means outside the, right? So this can be like, you had already said, like post-op. Adhesion. Adhesion can be also because of radiation. And then it can be also because of hernia. It can be because of volvulus. There can be a volvulus or an intussusception. So all these are different causes for mechanical obstruction. And when you come to the non-mechanical, the adynamic causes for intestinal obstruction, this because of paralytic areas, or it could be because of mesenteric vascular occlusion or pseudo obstruction. Okay, all these we had also seen in the previous day. Now, what are the symptoms that a patient with intestinal obstruction is going to present to you with? You have a patient coming to you, to your clinic, and the patient says, I have this, and this, and you know you are looking at intestinal obstruction. So what could that be? What is that combination of symptoms? Would you like to use the chat box? Yes, constipation, vomiting, and pain in the abdomen, Dr. 6. Yes. Any more? Absent peristalsis. Yes, you might be like auscultating and you don't get the bowel sound, right? Yes. Dr. Parvati Nair says there's probably no flatulence. The patient might, when you ask a leading question, like, are you passing flatus? The patient might say no. So that is also a very important point. Any more signs, symptoms of intestinal obstruction? Dr. Soruvapati also says that the patient could present with fever, and Dr. Shivakumar also says this tension of the abdomen. Absolutely, all of you are right. And let's just go to the next slide. And Dr. Kamakshi also says not able to eat. Patients in pain. There's going to be so much of vomiting, abdominal distension. All this is going to be a hindrance for the patient not be able to eat. Yeah. So Dr. Parvati Nair also says that patient could have rebound tenderness on examination if it is going to be a peritonitis. Yes, one of the clinical features or signs that we elicit on examination if the patient has peritonitis. Yes. So shall we move on to the next slide? Yes. So like all the symptoms that you all had just listed, why is the symptoms in a bowel obstruction? So that's what the slide is all about. In case of a partial or complete bowel obstruction, there is a colicky pain that happens because there you have the obstruction and the peristaltic waves are proceeding further till it reaches the level of the obstruction. And as the peristalsis moves on further, each wave comes and mounts on top of the other till it reaches the point of obstruction. It is going to present as a colicky wave. Okay, so that's the reason why the patient gets a colicky pain. And when there is an obstruction, there is decreased movement of the intestinal contents. Okay, so after the distal to the obstruction, so you have the obstruction here, and distal to the obstruction, you are going to have decreased movements of intestinal content. It's almost a standstill. So what is going to happen when there is no movement of the intestinal contents? There is going to be bowel distension, and when there is bowel distension, the gut wall expands, the epithelial surface area increases, and there is going to be increased bowel secretions, right? And all this, when there is a lot of bowel secretions, this is going to further present as nausea and vomiting in the patient. Now, there is also some amount of epithelial damage that is occurring as part of the inflammatory response of the bowel obstruction. Now, all this, when there is a release of the inflammatory factors, then it is all going to increase the pain or which is already present. Okay. So these are the different symptoms that you all had listed, and these are the reasons why this. Now, I had previously asked you all what are the symptoms or the signs which is going to tell you whether it is a small bowel obstruction or whether it is a large bowel obstruction. So why do you think that we are bothered about? I mean, obstruction is an obstruction. So why are we so bothered about, is it a small bowel obstruction or is it a large bowel obstruction? Any ideas on that? Yes. Yes, Dr. Shivakumar was talking about intestinal ischemia, the fingerprint. Would you like to tell us a bit more about the fingerprint? I am not too familiar with the fingerprint. Dr. Shivakumar, would you like to just add in about the fingerprint? It's a CT finding. Okay, thank you. And Dr. Deepa says causes differ. Would you like to add in a bit more into that? Yes, the causes differ. Okay, okay. All right, I get it. Yes, the causes differ. Okay. Why we are bothered whether it is a small intestinal obstruction or a large intestinal obstruction? It is probably, it could be because of, the cause itself for each of them may be different, and the symptoms, the symptoms, like earlier I was talking about, how would you know, is it a small bowel obstruction? How would you know it is a large bowel obstruction? Usually in small bowel obstruction, the vomitus volume is very large. There is a large amount of loss of volume. The patient could be going into dehydration faster than for large bowel obstruction. So it is important to know that. And even during planning, management of the patient, it is important to know whether you are dealing with small bowel obstruction or large bowel obstruction, right? So level of obstruction determines the pattern of symptoms. So if the patient is having a high level of obstruction, the vomiting develops early. So it is an earlier symptom and it is much larger in volume. Okay. There's a high fluid loss. And large bowel obstruction is rather progressive. It takes probably a couple of weeks to actually progress into symptoms which manifest classical of obstruction. And abdominal distension is more for large bowel obstruction. Okay, and when there is complete obstruction, like one of you was saying, there is no passage of flatus or fecal. Okay, there is no fecal. There is not even like that the patient says, yeah, I did try. There was only a very small amount of stool that I could pass. It's absolutely obstipation right here. Okay. Now, there is also something which can present, that is spurious diarrhea. So all this while we were talking about constipation, there is no fecus, there is no fecal mass coming, or there is no flatus that is being passed. So why are we talking about spurious diarrhea? Now, that is some completely opposite, isn't it? Somebody coming to your clinic and telling you that I am having diarrhea and not able to control. So why would it tell you that probably this patient is having a obstruction, a bowel obstruction? Any ideas on that? What is spurious diarrhea? Why are we talking about diarrhea when there is an intestinal obstruction?
Spurious diarrhea comes after a long term of constipation.
Yes.
So it Any obstructions with fecal impaction can cause spurious diarrhea.
Thank you so much, Dr. Saurabhati. And what would you ask the patient when they tell you that they are having a diarrhea?
We'll ask for a previous history of constipation.
Yes, absolutely, absolutely. So this is followed after a long period of constipation. Okay, so what happens is that when there is a long period of constipation, the fecal mass, which is actually obstructed, the upper part of the fecal mass starts to necrose and starts to liquefy and starts to come out. So this is perceived as diarrhea by the patient. And the patient might come to you telling that the patient is having diarrhea. And you would have to think a little ahead and ask the patient, when is the last time you had a normal stool? It is very important to ask this question when a patient comes to you with diarrhea, because you could think with completely opposite. You might think that it's a diarrhea, but whereas it was actually an obstruction. So it is very important to ask this very important question. That is, when is the last time you had a normal bowel movement? So the patient might tell you, if the patient is going to tell you that it's been about a week back, then it's absolutely a spurious diarrhea that you're looking at. And this spurious diarrhea has to be managed like a constipation. So what you would have to do is do a per-rectal examination. You can do a per-rectal examination and check for impacted stools. And if it is hard and impacted, you might have to even do a digital evacuation of the impacted stool and give an enema. So you can see how different is the management, where someone comes to you with complaints of diarrhea at a normal course, and when someone comes to you with diarrhea, which is a sequelae of obstruction. Okay, so having said that, let's move on. So diagnosis, how are you going to diagnose? So half your diagnosis has happened already, isn't it? We got the symptoms of the patient. You have been asking questions to the patient. You are doing your clinical exam of the patient. You have got the history of the patient. By now, you have almost reached the diagnosis. And in palliative care, where most of our patients are homebound, it might be difficult to actually transport the patient to an imaging center to take different images, like say, suppose an X-ray or a CT, or even coming to the point, is it justified? It depends. It depends. Is it justified to actually put the patient through an array of investigations in palliative care? Now, this question can be answered if you know what trajectory of disease that patient is. You need to understand that palliative care starts right from diagnosis. So if your patient is in the early part of the disease where all treatment is very aggressive, you are also supposed to be very aggressive in your treatment, because the patient is undergoing a definitive treatment for his malignancy. Now, when it comes further down to an advanced disease where the patient is undergoing palliation alone, you might have to think more along symptom care rather than, shifting the patient for higher end investigations, things like that. Like here, I have put down contrast radiography and things like that. So that's exactly what I had to bring out. I just wanted to point out while I put this list over here. So the most simple radiological investigation that you could do is take an abdominal X-ray. If you're suspecting an obstruction, an erect abdominal X-ray is what would tell you that whether the patient is having an obstruction. And as you can see here in this picture, there are typical features of an intestinal obstruction. I don't know. Let me just see if I can put my pointer here. Yeah. So as you can see here, the air fluid levels, yes, you can see a straight line and you can see a dilated groove. Okay, so these are the air fluid levels. Okay, so when you have multiple air fluid levels, this tells you that the patient is having an obstruction, an intestinal obstruction. Okay. So, well, there are other techniques also. You can ask for a CT scan of the abdomen, but most of the centers might either not have a facility or the patient has to be referred to another center for these higher end investigations, or there's probably a long waiting line for the patient to actually get that investigation done. And you cannot hold on your management for that patient, isn't it? Because time is valuable, the patient is suffering. So you need to make most of your diagnosis with the history, with the clinical examination, and with the symptom and signs of what the patient presents to you. Okay. And now, having got to the point of diagnosis, now what? We need to plan ahead for this patient. What is best for the patient? Not all patients are treated alike, isn't it? Like I said, palliative care starts right from diagnosis. So you could be looking at patients in the early part of the disease. You could be looking at patients at the end of life. And this differs. So we shall just go to an algorithm in the slide that you can see here. So when a patient comes to you with symptoms of bowel obstruction, yes, you do a clinical assessment. You could also do some radiological investigations, and which is justifiable at that point of time for the patient and for his disease stage. And then comes the decision making for the malignant bowel obstruction. MBO over here, I just put a short form for malignant bowel. So what is your decision making based on? So in this algorithm, there are basically two factors according to which you can make your decision. One is a patient factor. The other is the disease factor. And then you also have some technical factors on whether how invasive should you go about the investigations and things. Okay. So patient factors. What about the patient are you going to be looking into, which is going to tell you how much aggressive you have to be about it? Now I have put here age. So what ideas do you have about age being a factor here? Yeah. Chat box? Should age even be there? Or do you think there's a cutoff age? Yes, you can just put your ideas on the chat box. What is the age that you would say is the cutoff for your patient before you could plan a management, an aggressive management for bowel malignancy? I mean, obstruction. Any of you? I see no answers in the chat box. If the patient is debilitated, elderly, frail, Dr. Kamakshi says, And Dr. Deepa says less than 50 is when you think it could be aggressively done. Okay, so we do have the first point here. If the patient is debilitated, elderly, frail, yes, at this point of time, if your patient is not having a good performance status, probably you would not think about aggressive management, isn't it? But now when I say age is just a number. So what exactly matters is at that age, say if the patient is 60 or 70, what is the performance status of that patient? How much is he or she able to perform his or her duties without support? Okay. And how much bed bound is he? Is he able to walk around, do his own things? Then you have every right, or it is you are justified to plan a management in such a way that the patient's quality of life is not compromised at any cost. So again, I would like to say age. It just does not mean a cutoff here. You have to club it with the performance status of the patient. Okay. And then the stage of cancer. How advanced is the stage? Is it stage 1, stage 2, stage 3, or are we looking at stage 4? Okay. So also, what is the future anti-cancer treatment options for this patient? So probably the patient is being, the patient has, CA colon with liver mets, but the patient is being planned for second-line chemotherapy. And at this juncture, it doesn't mean that the patient has an advanced malignancy. So, we just manage it with conservative treatment. We will have to take the opinion of the surgical oncologist, the entire team here. Now, also malnutrition cachexia, like one of you had mentioned in the chat box, if the patient is frail. So that also could be one of the factors when we might not go for aggressive treatment. Now, other concurrent illnesses. So what is the point if the patient is having a chronic renal failure and we are thinking of going for aggressive treatment for malignant bowel, isn't it? So what is the point if the patient has a heart failure or a cardiac disease and you are planning on doing aggressive management? When I talk about aggressive management, I'm talking about surgical intervention. Okay. So when there is an obstruction, generally what is done for surgery is that the obstruction site is resected and excised, and anastomosis is done, or sometimes colostomy. The proximal end is brought out, and a bag is fit. That is called as a colostomy bag. So an ostomy is done for such patients. If it's a small bowel, a small bowel is also, the proximal end is brought out and the bag is fit. Okay. So generally what happens is that for small bowel ostomies, there is continuous fluid secretions that is actually excreted. So it is much difficult managing small bowel ostomies than large bowel ostomies. Now, coming to the disease factors. So the disease factors, which is going to tell you whether how much to manage your patient, is the extent of the obstruction. Okay, is it just obstruction at that one point, or is there multiple levels of obstruction? Or where is the obstruction? Is it like, a proximal, distal, or is it a functional obstruction? So if it is a hypokalemia that you're looking at, you really don't have to go for a surgical intervention, isn't it? All you have to do is correct the potassium levels, isn't it? So it depends if it is a functional obstruction or a mechanical obstruction. If there is a ascites is so that also, and along with that, even carcinomatosis peritoneal where the entire peritoneum is studded with nuts. So this again is a perfect to consider something interesting management like a surgical intervention. Now also technical factors like I said before, like the degree of invasiveness, endoscopy, interventional radiology, laparoscopy, all that, and the anesthetic requirement, whether the patient is able to go anesthesia safely, are all going to be the questions around which you make a decision on how you manage the patient. Dr. Parvati and I were saying, she thinks that the prognosis of some cancers depends about how the body responds to the cancer. Also can may depend on age. But definitely, again, I would like to say that it is also the performance, because earlier on, we would consider life expectancy to the 60 and below. But now we have to a point where Indian is almost. So if we have come to a point, people living quite a really long. So I think it so depends on how well that table is, and also the performance.
Ma'am,
How
sorry
well
to
you
interrupt.
do. Yes, yes.
You are not audible clearly.
Oh, is that? Is it audible now?
It's audible now. I think it would be better to keep the speaker a bit closer to your.
Okay.
Okay, ma'am, please go.
So, now so that is the slide. I was talking about the poor surgical prognosis.
Hello, ma'am.
Yes, can you hear?
I think it's not clear. We can hear you, but it's not clear. We are not getting the clarity.
Oh,
Can you please remove the headsets and try?
okay, yeah, that's what I'm going to do.
Yes, it's perfect now. Please.
Can you hear me now?
Yes, we can hear you, ma'am.
Okay, so I'll do this. Yeah, so I was talking about what are the different factors which can be a poor prognosis. Very
Ma'am,
yeah.
it's not at all audible.
Yeah, so we were talking about the poor prognostic factors. So again, if the patient has a low serum albumin or there is a severe nutritional deficiency for the patient, all these are poor prognostic factors. Then again, having a palpable abdominal mass or a previous radiotherapy which is already being done to the abdomen or the pelvis, or a history of combination chemotherapies. Now here, combination chemotherapies, what I mean over here is that the patient has had multiple lines of chemotherapy, okay? So, which means that the disease is rather resistant to treatment is what is meant over here, okay? And multiple sites of obstruction, when it is just not one site, but multiple sites, that also is a poor prognostic factor. And poor peristalsis due to diffuse carcinoma peritoneae or a poor performance status of the individual. All these are poor prognostic factors for a surgery for this patient, which tells you that we have to go for a conservative management. Okay? Right. Now, coming to the treatment for our patients who have been diagnosed, for whom you just diagnosed with malignant obstruction, they are definitely constipated, they are having pain, and like you said, nausea, vomiting, all this is present for the patient. So what can you actually do? So to address the pain component, you can try analgesics according to the WHO ladder, or if the patient is also having severe pain and vomiting, you can go for anticholinergics, because this is going to give you dual action, like buscopan, okay, like a hyoscine. So buscopan, you know that the generic name for buscopan is hyoscine butyl bromide, right? So when you give buscopan, what happens is that it has an antispasmodic action, and at the same time, it is also it also has an anti-secretory action. So the secretions are going to come down, and the volume of vomit is also going to come down. So you can also try other anti-secretory agents like somatostatin analogs. This may be an expensive option like octreotide, but it is just another alternative that you can choose for hyoscine. Okay. Now laxatives. Laxatives, you can try bisacodyl, or also you can try even senna, or you can try the lubricants, which is the glycerin, which is usually given. And you just had your previous class on what are the different laxatives that can be given for constipation, right? So you can try first of all, what has to be done is do a rectal examination, check for impacted stools. If there is impacted stools in the rectum, it means you have to do a digital evacuation of the impacted stools. Okay, and after doing a digital evacuation, you have to give a enema for the patient. And sometimes what is seen is that there is a ballooning of the rectum, which is seen. You put your finger in as part of the digital examination, digital rectal examination, and you feel that there is a ballooning, there's an empty area which is ballooned. And this tells you there is a higher end obstruction. So for that, what you have to do is that you have to give a high-end enema. So to the usual enema sachet, you attach a suction tube and you push it in with the help of lubricants. You push it up so that it almost reaches the topper part of the impacted fecal matter. And then you squeeze in the sachet of the drug. Okay. So that is about laxatives. And coming to corticosteroids. So why are we using corticosteroids here? Yes. Why are we using corticosteroids here? Chat box. Role of corticosteroids in intestinal obstruction. To reduce the peritumoral edema. Yes, Dr. Kamashi says to reduce the peritumoral edema. And Dr. Shivakumar says to reduce the inflammation and secretions. Dr. Vasanta says anti-inflammatory. Dr. Deepa says anti-inflammatory. Yes. So it has so many actions. Corticosteroids are used here to decrease the anti-inflammatory factors, also to reduce the peritumoral edema. So if you are going to have the lumen of the intestine where there is an obstruction of the tumor sitting there intramural, and it has an edema around it, so the corticosteroid is going to reduce the peritumoral edema around the tumor. So you are going to have some amount of patency in the lumen of the intestine. Okay, so which allows the passage of the contents. So it does not decrease the tumor size, it just decreases the peritumoral edema. And of course, it also has some other added effects like, having an effect on decreasing the anti-inflammatory factors. It also has, yes, Dr. Kamashi was saying, it's anti-emesis. It also acts it also acts as an anti-emetic factor, right? So that is why we use corticosteroids. And which corticosteroid is generally used?
Dexamethasone.
Dexamethasone. And the dosage? Any ideas on the dose? 4 to 8 mg is what Dr. Shivakumar says, and Dr. Kamashi says 16 mg. Yes? Anybody more? 0.1 mg per kg, Dr. Deepa says. Yes, when it comes to malignant bowel obstruction, Dr. Swarnendu says 4 mg TDS. Yes, okay. So, when it comes to malignant bowel obstructions, conservatively, we manage with dexamethasone, high dose dexamethasone. Okay, so what we usually do is that we start off with either a 16 mg dexamethasone. In some centers, they give 24 milligrams. So I personally used to give 24 milligram IV OD of dexamethasone. Okay, and preferably before evening. So never give your dexamethasone dose in the night, because it can interrupt with the sleep patterns of the individual. And also, dexamethasone has a rather long action. So you really don't have to repeat it 3 times, split the dose and repeat it 3 times a day. So you can just give it in one shot. It is just that it has to be given, ideally, you can give it in 100 ml NS, or, it has to be pushed very slowly, because it causes some amount of anal itching, a creeping like sensation for the patient, and some patients feel it very distressful. So a very slow IV, or you can just dilute it in 100 ml and give to the patient, and always remember before evening. Okay. So that would be your concoction for your patient. Laxatives, corticosteroids, laxatives again after your digital rectal examination, then corticosteroids, antiemetics, anticholinergics, somatostatin analogs, and analgesics. Okay. Now, surgical treatment would be resecting that bowel, which has the stricture or the tumor mass, or the one which is causing the obstruction, and which will be followed by a colectomy or a ileostomy, where the ileum is brought out, or where the colon is brought out of the abdominal wall. Okay, and invasive procedures, an NG tube can be inserted, or a gastrostomy can be done, or a colonic stent can be done. Now, these will be only in case where, there is a high-end obstruction somewhere in the early small bowel. Okay. Colonic stent, again, it is how aggressive you want to go about it, whether the patient affords it, whether it is only a single obstruction point that is there. Okay, that is only when you can go for a stenting. Yes, so we were talking about antiemetics. So antiemetics was one of the drugs that we were managing our patients with obstruction, right? So you can give a metoclopramide. Okay, it's a dopamine antagonist. You can start off with 10 milligram, 8 hourly subcutaneously. Or yes, so if the patient has an IV line, you can give a IV 8 hourly dose, or if needed, can be given even 6 hourly. Okay. So you can gradually increase the dose day by day, and at higher doses to like about, you can even set the a continuous subcutaneous infusion in a syringe pump. Okay, like say load it to about 30 to 120 milligrams over 24 hours in a syringe pump and give it to the patient. Now, again, one more thing we should keep in mind when it comes to metoclopramide for your patients is while giving parenteral metoclopramide, your patient can develop extrapyramidal symptoms. Have you all seen extrapyramidal symptoms? It's quite scary. I have seen 2-3 of patients developing extrapyramidal symptoms to metoclopramide. So it's quite scary when it happens for us as physicians or health personals, and also for the patient and the family. So be careful with that. And again, metoclopramide, if your patient is having a colicky abdominal pain, it might not be advisable to choose metoclopramide as an antiemetic. Why? Because the metoclopramide is a prokinetic as well. So metoclopramide is going to stimulate the peristaltic movements. Okay, so you have your obstruction, the patient has the obstruction point here in the intestine, and metoclopramide is going to increase the peristaltic movements of the intestine. And when it reaches the obstructive point, the further peristaltic waves are going to mount on, and this is going to increase the colicky pain of the patient. So metoclopramide might not be a good choice of antiemetic if your patient is having colicky pain. Again, if the patient is on anticholinergics like Buscopan, that is hyoscine, do not combine it with metoclopramide because both have antagonizing action. Okay, it cancels it. So that is also another point you have to keep in mind about metoclopramide, right? Now, again, another antiemetic of choice is 5-HT3 antagonists. Now, these are very commonly used, like the ondansetron, Emicet, right? So, these can be used in partial obstruction because ondansetron itself has some constipatory effects, right? So it can be used in partial obstruction and prokinetic action also. So again, haloperidol is yet another antiemetic for nausea and vomiting. That is 2.5 to 5 milligram can be given for your patient over 24 hours. Also, subcutaneous continuous subcutaneous infusions can be also given for patients with intractable vomiting. Okay. So we have 3 options here for antiemetics, and now anticholinergics. Okay, anticholinergics to decrease the secretions, like I said before, hyoscine butyl bromide can be given 120 milligram per day, can be given IV or subcutaneously, right? And also hyoscine hydrobromide is another choice. Corticosteroids, we did say dexamethasone 16 milligram per day, or sometimes, like I said, some centers also start off with 24 milligram per day. And what is done is that it is given once daily for 3 days or maximum 4 days, and it is observed if the patient is developing any signs of improvement. So how do you assess improvement for a patient who you have put on conservative therapy? You ask if the patient has passed flatus. That is the first sign that you can assess if there is some amount of progression to your treatment. Okay, so you can ask if the patient has passed flatus or if the patient has passed small amount of stools itself. Okay, so dexamethasone is given ideally before 3 p.m. Okay, and it can be given as a 3-day trial, and if vomiting subsides, continue as oral steroids. So now what you do is that if you have got after a 3-day or a 4-day trial, you bring down the dose dramatically and put the patient on a 4 mg dexamethasone orally. Once the vomiting also stops, you can just change it to 4 mg of dexamethasone orally for such patients, and gradually taper it down and stop it, right? And steroids act by reducing the peritumoral edema, which we had already discussed. Somatostatin analogs, like I said, octreotide, it is an expensive alternative. It reduces the secretion, slows down the motility, it reduces the splanchnic flow, it increases the absorption of water and electrolytes. It's a potent anti-vasoactive intestinal peptide effect, and it can also be given as a precocious dose. Okay, there are also depot preparations available, but they are very expensive, and it is given along with steroids in carcinomatosis. So ideally, this is how your prescription will look like. You write your corticosteroids first. There's injection dexamethasone, 16 milligram IV or subcutaneously, OD once daily into 3 days, then followed by your antiemetic, which could be metoclopramide if your patient do not have colicky pain, or you can give hyoscine butyl bromide if your patient has colicky pain, and also to control the vomiting, that is an anti-secretory effect. And again, haloperidol is another choice for antiemetic. And this definitely has also to be combined with the digital rectal examination and laxatives. Now, this is just a picture showing you how the stenting is done. Like you can see how the stent is being passed, and there is a self-expandable stent over there, which is pushing the tumor aside, making the lumen patent. You can see that in the picture D. Okay. The last picture, you can actually see how the stent is expanded, and you can and there is actually a lumen that was got. So now coming on to the common questions that the family asks you. Doctor, isn't that, or sister, isn't that this, he is not eating anything. So what should we do? Should we give him anything orally, or is it that, we should give him IV fluids round the clock? What do you think? Do we give such patients round the clock IV fluids? Or should we give the patient oral feeds? Or should we give them a total parenteral nutrition? IV fluids and TPN, Dr. Kamashi says. Swarnendu also says yes. We have to give IV fluids. Yes. Dr. Swarnendu says to check dehydration and electrolyte imbalance as well. Because patient is having so much of vomiting, you should also check for the electrolyte levels and also the amount of dehydration, and accordingly hydrate the patient. Okay. And Dr. Deepa also says it depends on the hydration of the patient. Again, there is a point here saying that, it all depends about how dehydrated the patient is. Yes, Dr. Parvati Nair says, now, doesn't it actually depend on the goals of care of the patient? Yes, you have to ask the patient, what the patient needs, definitely, because the ethics, the medical ethics, the first and primemost medical ethics point is the autonomy, where you ask what the patient wants. It is not what the family wants. It's not what the doctor wants. It is what the patient wants as well. We can ask what they want, and also, how aggressive are we on the treatment front? And is it just a symptom management that we are looking for? It depends on that as well, isn't it? Now, urine output is another question, is another point that Dr. Basanta has pulled out here. If the urine output is not adequate, probably that is going to tell us something about the hydration status of the patient, isn't it? So here, what I would like to highlight is that IV fluids may be given, but at the same time, it need not be that IV fluids are given round the clock. If you are able to control the emesis of the patient, you can promote simple sips of fluid for the patient. Simple sips of clear fluid for the patient. And IV fluids can be also used, but sparingly. The reason why we say that is that we know that the bowel distension and the vomiting, everything happens because of, the increased secretions in the bowel. Now, what is happening to all these IV fluids that we are pushing into this patient? Now, that also adds on to these secretions, and the vomiting is going to increase. So it is a very critical balance about how we hydrate the patient. Make sure we are not overhydrating the patient, because this is going to increase the secretions of the patient and increase the vomiting. Right? Now, Dr. Kamakshi also says it depends on his albumin levels, the electrolyte level, and the consciousness level. Yes. So also if the patient is having a low albumin, definitely there is going to be some amount of generalized edema and things like that. And again, electrolyte levels, because there is so much of vomiting, there is probably going to be a dyselectrolytemia, which has to be corrected, right? And a consciousness of the patient. Now, again, I would just like to add that very important point here. Are we dealing with a patient who is at end of life in the terminal phase? If it is a terminal phase, we might not be actually bothered about his electrolyte levels. Okay, because just correcting that magnesium, that potassium, that sodium is probably not going to change his disease stature. What actually matters is the symptom at that point of time, at the point of terminal care. So again, coming to the point where hydration has to be given, IV hydration can be given, but at a critical balance, because it should not increase the vomiting, right? And oral feeds, clear sips of fluid can be given as how the patient tolerates. And total parenteral nutrition. Okay, total parenteral nutrition is something that you preserve for patients who have a survival of more than 3 weeks. Total parenteral nutrition, earlier we could give only through, central lines. Now you can even give it through the peripheral lines, the pericabivan. So it is an easier option for many. When they think about the patient is nil oral for so many days because of the obstruction. But again, it is theoretically, it is meant for those who have a survival of more than 3 weeks, which clearly tells you it might not be the best choice for your patient who is at a terminal phase. Okay, and nasogastric tube insertions, it can be given if the patient has severe vomiting. And as there are patients who tell you that I'm so hungry, I want to eat, but I can't eat because I'm feeling I'm vomiting out everything. I mean, I have had patients in their terminal phase, or with obstruction, gastric outlet obstructions, or even intestinal obstructions, who have had nasogastric tube in situ as part of their hospitalization. And they used to tell me that they want to eat this, that they have these cravings during the terminal phase. And I just sometimes tell them, just have. Because whatever happens, whatever goes in, goes out through the nasogastric tube. And they get that satiety of having eaten that. That's one of their last wishes sometimes. So, that is one thing that I would just like to add here. And gastrostomy, whether it is actually justified at that stage of the disease for that patient, how much of survival actually does that patient have, is the question that has to come to your mind. Yes, so now let's come back to this case. I had put this slide earlier, and I had told you that these some words given here in red are going to give you clues how as to how you are going to manage this patient in palliative care. We are going to revisit this, but with much more detail. And I want you to think how you are going to manage this patient. Okay. So Sarah is a widower, supported by her children living in the UK. Sarah is 62 years old. She was diagnosed with stage 4 of gastric adenocarcinoma with metastasis to the peritoneum and anterior abdominal wall. So she has undergone surgery, palliative distal gastrectomy, and which was followed by chemotherapy. But what happened? After 2 cycles, she started progressing in her disease. Okay. Now, vomiting and abdominal colic she developed for 2 days, but was still able to pass small amounts of stool daily. So Sarah had vomiting 3 to 4 episodes per day, which was unrelated to meals. Vomitus was bilious with partially digested food. So if I'm asking you about this first instance, vomiting and abdominal colic for 2 days that the patient had, but was still able to pass small amount of stools daily, would you account this to obstruction? For a patient who is undergoing chemotherapy and is having abdominal vomiting, abdominal colic, and not able to pass stools as much, as able to pass only small amount of stools, what would that be mostly? Yes, it is a partial obstruction. Okay, that's what Dr. Kamashi says. Or it could be, the chemotherapy induced constipation, which has led to the partial obstruction, isn't it? Right? With impacted stools. So now Sarah has developed vomiting 3 to 4 episodes per day. It is just increasing, which was unrelated to the meals, whether she eats or not eats, she's just vomiting. And it is now bilious in nature with partially digested food. On examination, she was not dehydrated. Her abdomen was distended, bowel sounds were sluggish, and uh, palpable nodules on the abdominal wall, which was mildly tender. Yes. What is this telling us? Any idea? A bilious vomitus, 3 to 4 episodes, partially digested food, but she is not dehydrated. Her abdomen is distended. Bowel sounds are sluggish. Any idea? Progression of disease with obstruction. Yes, it is a small bowel going into a large bowel obstruction. Okay, now let's find out. In view of the persistent vomiting, a nasogastric tube was inserted. Sarah was told that the NG tube insertion would just be a temporary measure for her for decompression. So they take a CT scan and it shows a small bowel obstruction with a transition point, the proximal jejunum. So this was a small bowel obstruction. What is it over here that told us it is a small bowel obstruction? A clue? Yes. Many of you have agreed that earlier itself by listening to it that it is a small bowel obstruction. Absolutely. It is because it was a bilious vomiting that you already got to know that it is probably a small bowel obstruction, isn't it? Right. Now, as she was still opening her bowels, the impression was a partial rather than complete bowel obstruction. Intention of management was to reverse the obstruction. So an NG tube was put and a CT scan was done, and the intention was to manage her conservatively. So what do? she is passing very small amount of stools. So they give her a suppository, that is bisacodyl, and regular interval intravenous metoclopramide, that is 10 milligram metoclopramide was given to her 8 hourly, 8 hourly, and intravenous dexamethasone 8 mg was given to her per day. Okay. Now, for her pain, they started her on fentanyl infusion, 10 microgram. And this was a pain that had been present for 2 months. So this was the treatment. She was given bisacodyl, suppository, okay, and interval intravenous, regular interval intravenous metoclopramide and intravenous dexamethasone. So, and fentanyl infusion. So what do you see here? Anything that should have been done? Yes, I do see in the chat box how many of you had ideas about this was a small bowel obstruction, like the bilious vomiting and the passing of small amount of stools. And yes, thank you. So about the treatment, the suppository of bisacodyl, something that should have been done before that? Ideally. Fentanyl takes a long time. If it is a patch, it can take a long time. But infusions, rather, it has an instantaneous action. Yes, Parvati Nair has also asked about how severe was the pain and was the fentanyl actually justified, because these also induce constipation, isn't it? So absolutely, we would want a pain score here. And what kind of pain was it? Was it a continuous pain? Was it a colicky pain? So would we have had a better agent for colicky pain here, to address the colicky pain here? So these are all questions that have to go through your mind. And before you put in a suppository for your patient who is having obstruction or having constipation, it is a must to do a digital rectal examination to see if there is impacted fecal stools. Because if you are going to push the suppository into the fecal mass, it is not going to make any difference. So a suppository should be in contact with the mucosal surface of the rectal wall. So that is important. So Dr. Kamashi says you can put in an NG tube and give the laxatives. That can also be done, but we have to also control the vomiting at the same time, isn't it? So let us see what else happened to her. No bowel action. The intravenous metoclopramide was increased to 60 milligram per day on the following day. Marked clinical improvement was seen because we know that metoclopramide is a prokinetic as well. And the NG aspirate had significantly reduced volume because she had no more vomiting. So the team doctor was very happy and pulled out her NG tube and start her on oral medications. Now, intravenous metoclopramide and dexamethasone were continued for 2 days and then just stopped. And 3 days later, she started to vomit again. Now, what went wrong there? What went wrong there? Would you like to improve something in this point? Well, she did have a market improvement, and the NG tube was, pulled out. I'm sorry, over here, and Sarah was put on oral medications. And now that she's on oral medications, all the IV, metoclopramide, and dexamethasone were continued for 2 days and then just stopped. Okay, so what do you think? Through NG, okay, it was too early to remove the NG tube, is one of the suggestions. What else? Anybody else has any suggestions here? What went wrong? It's a stage 4 disease. Okay. So probably, yes, probably what you were trying to say is that the disease is going on progressing. So probably it would have been advisable to keep the NG tube so that, as and when the progression is happening, we can manage it accordingly. Okay, any other suggestions? I shall come back to that point. Yes, any other suggestions in the chat box? Anybody? So what we can see here, serum sodium and potassium was not looked into. Okay, so whether it was any electrolyte imbalance which is contributing to the obstruction, we do not know. And Dr. Chidananda also says about the early restarting of feeds. Okay, right. And I would like to just pull out a point over here. Intravenous metoclopramide and dexamethasone were continued for 2 days and stopped subsequently. For somebody who is having features of obstruction and particularly malignant obstruction, if you have started the patient on steroids, which has markedly given her a change, her or him a change, so definitely you have to taper it down before you stop it. Okay, so here what has happened is that patient was on antiemetics, prokinetics, and dexamethasone, right? And was stopped. Uh, it was stopped all of a sudden, which led to the repeat of symptoms in 3 days' time. So what happened now? She has 3 episodes of vomiting, which contains moderate to large amount of bilious vomitus. So where is the obstruction now? Large amount of bilious vomitus. Yes. The patient has a large amount in the small bowel, right? Thank you. So the patient has a small bowel obstruction, which is progressing and leading on to the complaints of severe vomiting. And this way, the metoclopramide was stepped up. Yeah. So, excuse me. I can hear myself echoing. Are you able to hear me fine?
Yes, ma'am, we can hear you. We can hear you clearly.
Really? Okay. Right. So what happened is that metoclopramide was stepped up after that. Dexamethasone was also started. Then it was a panic. Whatever was stopped was restarted again. And but somehow her symptoms persisted. And again, ranitidine was also added. Okay, intravenous ranitidine was also added to decrease the secretions. Now, the goals of care was established after discussing with the patient and her family. Now, this is when the goals of care were actually explained to the family. Now, we know that Sarah's family was in the UK, and it was much later that actually they started discussing on the goals of care of Sarah to the family, or what should be done, what should not be done, what is her preference, what is the family's preference, who is there to take care of her, how are we going to manage the sequelae of the events that is going to come up in the progression of the disease, and where will she be? Should she be at home alone with a caretaker, or should she be shifted to a hospice? A lot of things like that. So all this was discussed, and she preferred to keep the NG tube for decompression while she enjoyed taking fluids orally. So, like one of you had suggested, keeping the NG tube in there for some more time was what Sarah also wanted. So she just had to clamp the NG tube when she was better, and she would just eat orally, right? And the treating team decided to stop all further chemotherapy and shift to comfort care alone for her. And what was done is that she was returned home and was connected with the local hospice support. So that was the case that we were discussing. And before we conclude, I just want to add a word about bowel irrigation. Most patients who have a colostomy, it is very difficult to manage a ileostomy, okay? And there is a lot of soiling and lot of secretions that keep happening. There is excoriation of the skin that keeps happening. It's very difficult to manage ileal ostomies, okay? But colostomy, most often, at least it is better managed. And the ostomy bags can be those with adhesives, or they can be with a belt attached. And often what is distressing is that even if the patient has recovered from the illness after his treatment course, he is not able to get back to his routine activities because he is so overconscious about the bag getting filled continuously and the order that is being emitted, that he tries to, uh, uh, he tries to be away from all his friends and family, and most of the time tries to seclude himself. So what can be taught to the patient is bowel irrigation. By doing bowel irrigation, we can tell the patient that he can tune his ostomy, he can tune his bowels to a particular time. These are the different things needed for bowel irrigation. You can see the irrigation bag with a cone tip at the end of it. You can see an irrigation sleeve, okay, and a clip and the ostomy belt. So this is how it is done. Every morning, the patient is asked to irrigate his ostomy. Okay, that is, the irrigation bag is filled with lukewarm water, not hot water, but lukewarm water. And you can see that there is that cone tip over here, right? And this tip is put into the ostomy tube, uh, and the water is, the irrigation bag fluid is let to flow into the ostomy. Okay, and after that the sleeve is attached so that the bowel is washed out, and you can see how the sleeve is placed into the commode. So if this is practiced for about 21 days to 28 days at a stretch every day at the same time in the morning, what happens is that the patient develops a habit of evacuating his bowels at the same time every day. And this helps the patient to get out and continue with his work and socialize with people. So I personally know an orthopedician who had a CA Colin, who had a colostomy and was so depressed after he got he completed his treatment for cancer and was completely cured, but still he was not able to go back and start doing his surgeries until he discovered how he could practice irrigation, and he could, have a controlled evacuation of his bowels at a timed fashion, and he could get back to work. He could spend hours at his OT doing his surgeries. So by that, we come to the end of the session. And I hope by now you know what are the different ways how we classify intestinal obstruction, and what are the symptoms of your patients that tell you that this is an obstruction that you're looking at, this is a small bowel obstruction that you're looking at, this is a large bowel obstruction that you're looking at. You really don't need those CT scans to understand where the obstruction is, isn't it? And also how to diagnose and how to manage your patients, and how to actually plan the care for your patients in palliative care. And the algorithm, remember the algorithm? That is also very important, right? So thank you very much, everybody. You all were very active in participating, and it really kept the discussion going very interesting. Thank you so much.
Thank you so much, ma'am, for that wonderful session. There are any questions? It's time for that. The floor is open now.
Yes, any questions?
Can I ask, madam?
Yeah,
This is regarding the
yes,
subcutaneous infusions,
yes, please.
what we are going on talking about. I don't know, I have my
Huh.
own reservations because most of these patients,
Huh.
especially post malignancy, they are quite sick, debilitated, cachectic.
Hmm.
How well do they
Hmm.
tolerate the subcutaneous infusions, madam? Because that itself can
Oh,
be a source of infection or further discomfort. Whatever is the limited volume, or if you are giving it as a continuous infusion, that itself can cause a lot of discomfort and can be a source of complaint for in the next stage. That's what I have feel.
okay. But somehow in practice, like actually what we have seen is that subcutaneous infections, I mean, infusions can be easily tried for debilitated patients also because there is no difficulty in IV access over here. And you just have to be careful about what drugs you're giving. Like say, NSAIDs is something that you cannot give through a subcutaneous infusion. So most of the drugs, and in fact, they can be combined and given through the subcutaneous infusion. Whereas in IV, you might have to go, in IV, sometimes they might be superficial thrombophlebitis or things like that. You have to keep changing. So these problems are not encountered actually in frail patients, debilitating patients. So in fact, we have found it much better with subcutaneous infusions. It is just that the expertise sometimes it and sometimes the institutional policies are different in different places. So practicing subcutaneous infusions might be difficult sometimes in certain areas because of that.
Because especially post chemotherapy,
Hmm.
the peripheral venous access is very poor.
Yes, yes,
It's very difficult to get a peripheral venous
yes,
access. And
yes.
what will be the role of this? See, this something like a peripherally introduced central catheters, which can
Huh.
be kept for a long time, especially
Yes,
in the palliative care. This thing,
yes,
so which can be kept for a long duration, which are
yes.
more comfortable and more acceptable by the patients. That's what I.
Yes, yes. PICC lines can definitely be a good a way to for IV access because it's always a ready access. Only thing is that we have to make sure the PICC line care is adequate. We do not want sepsis creeping in, through that because after all, it is a central line. And again, flushing these PICC lines regularly, that is also very important to keep it patent. And then PICC line induced thrombosis is also another uh, problem that we could come across because in malignancy itself is high risk for venous thrombosis, right? So these are all some few areas where which makes PICC lines risky in long-term palliative care. So generally in palliative care, where most of these patients are at home, they are not able to do their regular PICC line flushing and things like that, and the care. Sometimes sub-Q is much easily managed at home settings.
Of course, the decline is not that it's not associated with any problems. It can be associated with problems, but can be more acceptable to the patient. That's what I feel. More,
It
it's,
can be, as long as there is taken good care,
because,
it can be.
yeah, because when you teach the patients about the care of the nasogastric tube, the caring of
Hmm.
the colostomy, managing this PICC line also, I don't think it's as cumbersome as managing a colostomy. especially what they need is proper asepsis and maintaining the fluctuation,
Yes, yes.
flushing, which can be easily learned by the caregiver or the patient themselves. That's what this thing.
Mm-hmm. We have so far not tried telling the patients and the family to flush the PIC lines, uh, probably thinking of the risk of it. But I think we will have to think about it, like how safe it will be. Have you had personal experiences where you have taught the patient or the family on PIC line flushings
Yes,
at home?
madam.
Yeah.
We tell them how to,
Uh-huh.
and what should be the volume, how to prepare the heparinase saline for flushing, and
Oh,
how
okay, okay.
often it has to be. Because see, thing is, most of the patients and the families, they can understand the simple instructions. Keep it as simple as possible. Try to show them.
Mm.
And usually, what we do is when they are in the hospital, the one caretaker is identified. One caretaker is identified, and
Hmm.
who gets trained when the nursing staff are doing all this procedure. They observe for a few days, then they start under supervision. They start doing while they're in the hospital, and
Hmm.
subsequently when they discharge, we know that in the week, about week to 10 days time, they're able to. They have confidence in managing things. That's when we decide to send them back home.
Mm-hmm. Okay.
Because we involve the caretaker, identify one caretaker from the family at the earliest stage itself, and
Mm-hmm.
ask them to be around and get trained while they're in the hospital. Not that as an instruction,
Mm-hmm.
send them back home and expect,
Mm-hmm.
expect nothing happens. So we usually see them under supervision for
Mm-hmm.
about a week to 10 days
Right.
in the hospital. Then once we are sure, yes, then we know that that is the time usually the patient also takes to settle down for whatever procedure, and when
Mm-hmm.
when it is safe to discharge them back home with the
Okay. All right.
adequately trained caretaker. In fact, for the
Mm-hmm.
tracheostomy care, everything we have to train them. Tracheostomy care, peg tube
Yeah.
care, and feeding through the pig tube.
Mm.
It's the only thing is it's just a bit of additional commitment from the medical staff, that's both the nursing staff, to train the caretaker.
Mm.
That's what
In
is.
absolute aseptic measures.
Yeah, yeah.
Yeah. Right.
I think,
We have a question here, like role of neurolysis. Oh, sorry, did I interrupt you?
no,
Sorry,
no, 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 not
you
at
were
all.
talking.
No, not at all. Thank you, thank you.
Yeah. Thank you so much for that discussion. And we have a question here, role of neurolysis for continuous abdominal pain. Would you like to tell us a bit about that, Dr. Deepa?
Ma'am,
Yeah.
pertaining to celiac plexus block,
Mhm.
neurolysis, something like that.
I do not practice intervention pain management. So I might not be the right person probably to talk to you about neurolysis. Maybe if we have somebody in the group here who does interventional procedures.
Can I? Yes, definitely the neurolytic pain or as this thing, they have a definite role when other modes of pain management have failed, or like if you reach the maximum dosage of morphine and still
Mm,
the patient
yeah.
has this thing.
Like for pancreatic pain and all that,
Yeah,
definitely it's
yeah.
actually it becomes one of the first choices. Celiac
No, it's
plexus
not
blocked and all
only
that.
the celiac plexus, even the stellate ganglion block for upper limb
Yes,
pain,
yes,
thoracic pain.
yes.
There are so many other blocks which can be administered. Only thing is a person performing the procedure should be confident enough that there is this thing. Usually what they do is they give a diagnostic block with a local anesthetic, see that
Mm-hmm.
the patient, the pain relief is adequate with that block. It's going to help the patient. Then may I call the patient back again and then do the permanent neurolytic block using whatever different
Okay, okay.
ablative chemicals which are used. Either absolute or
Okay.
So usually it's not the first attempt go with the ablative blocks. Do a diagnostic block, ensure that it is safe and going to benefit the patient, and then you perform the ablative block in the next stage.
Mhm. Okay. Thank you, sir.
Thank you, sir.
Right.
Uh,
Do we have any more questions for discussion?
think if there are no more questions, I think we could wind up the session, ma'am. Thank you so much. It was a last minute request and we take up and it's great. Thank you so much for that detailed presentation and session. Thank you so much, ma'am. And thank you all for joining with us for today's session. The feedback link will be shared in your WhatsApp group. Thank you all. Bye-bye.
It's really that